I'm going to introduce our speaker this evening. We're very fortunate that we were able to get such an interesting speaker and topic for an August meeting. Often it's very difficult, as you can understand, to get people out for this. And so yeah, it's really great to see so many faces here, and we're really happy to have our speaker here this evening. Our speaker is Sheila Garland. Sheila holds a master's degree in clinical psychology from the University of Calgary, and is currently conducting her doctoral research, which is investigating programs for people with insomnia and cancer. Her program, called I Can Sleep, is delivered out of the Department of Psychological Resources through the Tom Baker Cancer Center. Her interests in the area are in the areas of health psychology, psychosocial oncology, and behavioral sleep medicine. And she regularly lectures on sleep to patients of the Tom Baker Cancer, the TBC community groups. Okay, so there's supposed to be a space and community groups, very good. And she holds a fellowship from the psychosocial oncology research training initiative and the Social Sciences and Humanities Research Council. She was going to talk about, she's going to cover sleep physiology and biology, introduce some common sleep disorders with focus on insomnia, and provide you some practical suggestions on things you can do to improve sleep, and where you can go if you need more help. So if I can get a hand, yeah.
Okay, can everybody hear me all right in the back? Great. All right, wonderful. Thank you very much for that introduction. Yes, so my name is Sheila Garland. I have been working with people who have been diagnosed with cancer since 2004. So primarily I've been investigating programs designed to improve quality of life, right? That's a very general sort of topic. Really, what does it mean? And when I think about things that influence quality of life, I think what's really, really important, and what I think is really, really important to your quality of life, is the sleep that you got the night before. Right? So it influences so many things in somebody's life. It influences your mood, it influences your activity level, your physical functioning, it influences your health, it influences your relationships with others, your work, your ability to tolerate treatments, everything else. So I really started to focus on sleep more as, if we can improve sleep quality, then maybe we can improve quality of life, since it's such a big determinant. Now, I know that insomnia specifically, and sleep disturbances more generally, are extremely common in individuals who have a previous or a current cancer diagnosis. Recent research suggests that anywhere from about 30 to 50% of all individuals who have been diagnosed with cancer will experience sleep disturbances or insomnia at some time during their treatment. Now, for some people, this tends to go away with treatment ending, but for about 1/3 of those people, this insomnia tends to persist even after treatment is completed. So that's why it's really important for people to know what is insomnia, and then if I have insomnia, what do I do about it? So I'm hoping that you guys can read this comic up here, and if you identify with it, you know you're in the right place. Has everybody sort of experienced that at some point in their life? Okay. All right. Well, I have 4 objectives that I'm hoping to cover tonight. First of all, I'm going to give you some basic facts about sleep. I'm always surprised at how little the general population knows about sleep. Then I'm going to specifically focus on insomnia, tell you what it is, what it's not, and how it typically develops in individuals. And then I'm going to give you some practical suggestions on what each one of you can do going home tonight to help yourself sleep a little bit better. And then by the end of my discussion today, if you figure, you know what, I really think I've got a problem and I need to talk to somebody else about it, maybe get some professional help, then I'm going to tell you where you can go to get that. All right. So first of all, what are some facts about sleep? Now I'm hoping that by showing you the types of sleepers, that during my presentation I don't have anybody with failing systems. All right, so I'm going to try and keep it upbeat, try and keep you engaged in my presentation. Okay, first of all, sleep medicine is very young. It's really in its infancy in terms of medicine in general. We only discovered that people sleep in stages in 1953, and most of what we know about sleep we've really only learned in the past 25 years. So, what we do know, fact number one, is that individual sleep needs are highly variable. When you leave this room, I want you to toss out that notion that 8 hours is the gold standard that you need to be sleeping. That's an average because it's an average. It means some people sleep less and it means some people sleep more. So typically, people will sleep on anywhere from about 4 to 10 hours. You've got those people who are short sleepers that get by on 5 hours and they're functioning and they're getting everything done and they're effective. Anything more than that, they feel groggy. They don't feel that they're most productive. Then there's those people who are the long sleepers, right? Those are the people who need 9, 10 hours. Anything less than that, you might as well be a zombie at that point. That's why we get the average, but that's really, it's not saying that that's ideal. Really, it is very subjective. So what a good sleep is something that you feel good after having. Right? So if that means you feel good after having 5 hours of sleep, great. That's what your body needs. If you feel good after having 9 hours of sleep, great. That's what your body needs. And then if you happen to be in the average range, most people are, then 7 or 8 hours is what's typically considered normal. Now we do know that our sleep needs can be temporarily altered by things going on in our life. So emergencies, all of these catastrophes that happen around the world, you've got medical personnel that go for 3 days without sleeping, right? Then their body eventually catches up with them and they crash and they sleep for a very long time. Workloads, when we've got a deadline coming up, we've got something to do, we've got company coming over and we need to clean the house or something like that, we can get by on a little less sleep. Everybody who's had children know that typically our sleep is altered during certain periods. If you've got teenagers who stay awake or stay out all night and keep you awake. Pregnancy also changes sleep. Travel, anybody who's changed time zones know that jet lag is an obvious thing that happens after traveling for certain illness or for certain destinations, and also medical illness. So whether we have the effects of the treatment itself, whether we have pain, whether we just have a lot of fatigue, all of those sorts of things can influence temporarily our sleep needs. But ultimately it is a very subjective experience. Fact number 2 is that we sleep in stages. Now our sleep is broken down into 5 stages. Major categories are non-REM sleep, and that's stages 1 through 4, and then also REM sleep. And REM stands for rapid eye movement. So we've got 5 stages, 4 non-REM, 1 REM. And we can tell which stage of sleep we're in by looking at our brain, because our brain behaves in a particular way when we're in certain sleep stages. So I don't think I have a pointer. Do I have a pointer? No? Okay. Well, I'm just going to point, actually. So I've got a finger, it's a pointer, old-fashioned pointer, really. So if you see up there, you can see when we're awake, our brain is very active, right? Those are our brain waves. It's a little electrical activity. It says that our brain is functioning, it's moving around, thoughts are moving around, we're thinking about things. But then when we calm ourselves down, we're still alert, but we're calm. Right? Our brain waves change, right? They tend to almost lengthen a little bit. If you can think about our brain waves as a coil, right? When we're thinking a lot, when our brain is very active, the coil is very tight and strung closely together. Now, as we relax, that coil also relaxes. Okay? So that's what you can see happening in stage 1. And that's what is called theta waves. All right? So basically, it's just our brain relaxing. Now, stage 1 sleep is the first stage of sleep that we go into when we're falling asleep. It's really when we kind of feel like we're falling asleep. It's our subjective experience of falling asleep. It doesn't last very long, maybe 5-10 minutes. Sometimes people will experience what's called hypnic jerks. In stage 1, that's when you feel almost like you're falling and then you go like this, right? And then you kind of wake yourself up and you're kind of embarrassed because you're like, oh, okay, what's going on, right? Very normal, often happens during stage 1 sleep. But stage 1 is just really a transitioning from wakefulness into deeper sleep, so it doesn't take us very long. Now stage 2 is where we spend most of our night. Stage 2 is characterized by specific brainwave patterns that only happen during that specific stage of sleep. So you can see there that there's a sleep spindle, and that's just really, really close together brainwaves. And then also this K complex, which is just a very sort of tall, robust little electrical pattern. Okay? Like I said, we spend most of our time in stage 2 sleep. Now stage 3 and 4 sleep, this is our deepest sleep. Okay? Now you can see how far apart our brain waves are and how big our brain waves are during stage 3 and 4 sleep, also called delta sleep. Now this is a very important sleep stage because this sleep stage is associated with repair and restoration. Okay, with teenagers, kids spend a lot of time in stage 3 and 4 sleep. That's when all their growth hormone is being pumped out into their system. They spend a lot of time in stage 3 and 4 sleep. Now REM sleep, you can see the brain waves that we have during REM sleep are very similar to the brain waves that we have when we are awake. That is because our brain is as active when we're in REM sleep as when we are awake. Now, REM sleep is often associated with dreaming, right? We think that that's the only time we dream. We actually dream in all of the stages, but in the other stages, in the non-REM stages, we're more likely to dream about things that, we've thought about earlier, Okay, so why did this person say this to me? And then you dream that you're having a conversation with that person or something like that. They make more sense if we're dreaming in non-REM sleep. When we dream in REM sleep, what REM sleep is associated with is a lot of memory consolidation. So what I imagine is, these little men in our brain moving memories from short-term storage to long-term storage, and they're moving things around and they're filing things away. And that's why oftentimes the dreams that we have in REM sleep don't make sense. They're a hodgepodge of stuff, maybe stuff you did that day, stuff from childhood, stuff you want to do, and what your brain is just really trying to do is make sense of all this stuff that you've either done, you're currently doing, or you're going to do. So really that's what REM sleep is. REM sleep is extremely unique though, because we're actually paralyzed during REM sleep. There is a switch in our brain that gets flipped, that when we're in REM sleep, the only thing that's still going on is all of our vital functions, and the only muscle that we can move is our diaphragm. Now, if you can imagine, that's a protective mechanism to prevent us from acting out our dreams in our sleep, right? So if you're dreaming that you're flying and you're jumping off buildings and everything else like that, if you weren't prevented from moving your major muscles, you might jump out your window, right? And people have done that. It's actually a disorder called REM sleep behavior disorder. It's something that's malfunctioned in your brain that causes you to act out your dreams. Very different than sleepwalking. Sleepwalking happens in other ones. But that is a unique feature of REM sleep, as well as eye movement, which is how it's categorized. Okay. Any questions about sleep stages? Okay. All right. Fact number 3 is that we cycle through these sleep stages throughout the night. All right, so you can see here at the corner, we're awake, and then we've got REM sleep, and then we've got our 4 non-REM sleep stages. So we start out just a little bit in stage 1, we move down into stage 2, spend a little bit of time stage 3, then we spend time in stage 4, and then we go back up, then we hit a REM period, brief REM period, then we go back down, and we go back up, then we hit another REM period, then we got to get up. Maybe we got to go to the bathroom. So we're awake for a little bit of time, we go to the bathroom, then we go back to bed. And then we have more REM periods, and we have another awakening, and then we have more. So this is normal. It's actually quite normal for people to have at least 2 awakenings that they are conscious of in the night. We actually arouse ourselves quite frequently, anywhere from about 5 to 15, 20 times. Our brain will arouse itself out of sleep. We may not be conscious that we're aroused, but we are aroused out of sleep, and that's sort of something that when you monitor your brain, you find out. Now, I have a couple questions here. Now, if you look at the difference between the first half of the night and the last half of the night. What is the difference there that anybody can see between those two halves of your sleep? Somebody shout it out.
No deep sleep.
Yeah, exactly, right. So you're getting more deep sleep in the beginning of the night and more REM in the latter part of the night. Now, if you think about your sleep in your brain like a child, right? It wants to get the good stuff first. It's like, a kid who's got a, older brother who's going to steal all the good stuff on his plate, right? So he's got to eat all the good stuff first so nobody else takes it. That's kind of like our brain too. Our brain wants to ensure that we are going to get our deep sleep. Something might happen that prevents us from getting it later on, so it's going to get what it wants first. So this is often very reassuring to people who might have awakenings later on in the night. They figure, oh, I've woken up, my whole night is ruined, right? Actually, probably not. You probably got most of your deep sleep already by the time you woke up, because most people will experience their first awakening about 3 o'clock in the morning, right? So you've already gone through these sleep cycles. Each sleep cycle, when you're going through, usually takes about 90 minutes, right? So depending on what time you go to bed. Now, in the earlier morning, that's when we're experiencing more of our REM sleep. Now, that's why we often wake up and remember our dream, because we're more likely to have awoken up in very close proximity to a time when we're dreaming. Okay. Now, I hear a lot of people say, you know what, I don't want to have anything to do with these sleep stages. I want to go into deep sleep and I want to stay there the rest of the night. I don't want nothing to wake me up. Now, that's all well and fine, but does anybody see any advantages of having this cycling sleep pattern throughout the night? What might that be good for? Think evolutionarily. Well, if we went into deep sleep and we stayed in deep sleep all night, we wouldn't be able to become alert to a baby crying, a house fire, anything else like that, because when we are in our lighter stages of sleep, that's when we're going to notice, oh geez, my bladder's kind of feeling full. Or, oh, okay, I hear a child crying. Or if I'm a caveman or something like that, oh, there's a saber-toothed tiger outside my cave, right? If we didn't cycle through these sleep stages, our species probably wouldn't have survived to produce offspring, or, we wouldn't be around. So this has a very practical benefit to sleeping and cycling through our sleep stages, okay? Now, fact number 4, our sleep changes with age, right? I actually probably think that most of you, know that already. You don't sleep like you did when you were 21, right? So there's a reason why. Now, if you can see in this graph here, we've got total sleep in minutes on the one side, and down here in the bottom, we've got age. Now, I've described now the different sorts of sleep stages. So you can see down there bottom, that's the delta sleep, that's the deep sleep at stages 3 and 4. Then we've got our stage 2, which you can see we do spend most of our time in stage 2 sleep. Then we've got our REM sleep. Then we've got our stage 1. And then we've got the time we spend awake in bed. Now, can somebody tell me what's obvious about the changes that we experience in our sleep as we age? Absolutely, less delta sleep. Now, if you recall what I said delta sleep was good for repair and restoration and growth, right? So this isn't the only thing that is responsible for the fact that when we were 21 and we could get into a motorcycle accident and we could be walking around the next day and we could be fine. But if we got into a motorcycle accident when we were 55, we'd probably, break our, hip, and then, we would get gout or something like that too. And, it would take a lot longer to heal from the exact same accident than we had when we were 21 than we did if we had the same accident when we were 55. Now, a lot of other factors are involved, but one of the factors is that we are not getting as much deep restorative sleep as we age. Okay? And we're also getting less sleep in general. So you can see there, kids spend a lot of time in delta sleep, but then also a lot of time in REM sleep as well, because all of their neurons are being, their neuronal patterns are being formed and everything else like that, all their brain development. But that sort of levels off, right? The other thing that changes is that we do experience a little bit more stage 1 sleep. And we spend usually more time lying awake in bed as we age. So our sleep becomes lighter, it becomes a little bit more fragmented, we become easier to arouse and everything else like that. So I don't really like this slide because I think it's depressing, right? Because I'm heading in that area, right? I don't really like that. But I also think it's a fact. So, you know, we deal with facts is all we have. But that's not to say that, okay, well, you know what, your sleep is ruined. There's lots of things you can do to improve the quality of your sleep, and we'll exactly get to that. All right, fact number 5 is that biological systems influence our sleep. So there's lots of other things that are going on. It's very complicated. One of the main things that influences how much we sleep when we sleep is something called sleep pressure. Now, our sleep system is like a homeostatic mechanism, right? So the longer we don't sleep, the greater the probability we will sleep soon. And the more tired we get, that's common sense, right? So it's like, you know, food. The longer we haven't eaten, the more hungry we get, right? So now if you think about if you get 8 hours of sleep and you wake up at 8 o'clock, right? We all operate on a 24-hour rhythm, right? Circadian rhythm is, circa is approximately, and dian is day, so it's approximately every day we cycle throughout these rhythms, right? So now if we wake up at 8 o'clock in the morning, we get 8 hours of sleep, and we operate on a 24-hour rhythm, then we're going to need 16 hours of sleep pressure to build up in order for us to feel tired again. So that means we probably won't feel tired until midnight. Right? Well, that's too late for people to go to bed. Really? Who goes to bed at midnight? Right? So a lot of people will say, you know, okay, well, I'll go to bed at 10 because that's what time I go to bed. That's bedtime, right? But if you wake up at 8 o'clock in the morning and you've gotten your what's ideal for you might be 8 hours, right? Then you're going to bed too early before your body's ready to go to sleep. All right, so this is how it sort of balances out. You get less sleep, you balance with more sleep. You get more sleep, you balance with less sleep. It's all sort of on this regulatory mechanism, but one of it has to do with your sleep pressure. Okay. Melatonin. Melatonin is a hormone. It's produced by the pineal gland deep in our brain, and it's only produced in the absence of light. And it is produced before sleep onset. So it's a hormone that tells our brain it's time to fall asleep. So it becomes difficult when it's light out right now to keep the same schedule as we keep in the wintertime because we might have the windows open, it's bright light, everything else like that. People who are on the computer until late at night, right? The computer is actually bright enough to stimulate daylight because it's approximately arm's length in front of our face, and it actually suppresses the production of melatonin because the light is bright enough and it goes through our retina. Okay? So melatonin is very important. Our body temperature also cycles within about a degree, either up or down, throughout the day. And a drop in our body temperature signals to our brain, okay, sleep is coming. Cortisol. Cortisol also fluctuates throughout the day. Cortisol is a stress hormone. It's highest in the morning, so if you can think it's high, and then it basically just drops down. So you want it high in the morning because it gets you going, right? You want energy to go and tackle the things you've got to do during the day. And then at night, you want it to be low because you don't want to be activated. You want to be relaxed. Other hormones or other things that are involved are things like thyroid hormones. Anybody who's hyper or hypothyroid, either one of those can cause sleep disruption. Adenosine is another hormone that is produced before sleep onset. So caffeine actually blocks adenosine receptors, and so it only blocks them temporarily. But that's actually why caffeine works on our brain to make us not feel tired, is because it blocks these adenosine receptors. And GABA is another hormone in our brain, another neurotransmitter in our brain that works. It's complicated, but the key message is that we can work with these systems in order to improve our sleep. All right, now this is circadian regulation. So this is some of the stuff that I was talking about before, and this is how it fluctuates throughout the day. So you can see our core body temperature. It kind of raises, it drops before our sleep period, and then it rises. And that is what signals to our brain it's time to wake up. Does anybody ever feel cold at night, so they just pack on all the blankets, and then in the morning they're hot, they've got all the blankets kicked off? That's why. Now, sleep propensity is almost in direct opposition to our core body temperature. So sleep propensity is the chance, the likelihood we're going to sleep, okay? Now, what about that little blip that we see there? What time does that correspond to? About 3 o'clock in the afternoon. What happens to everybody at 3 o'clock in the afternoon? We get tired, right? So you can see the little blip in our core body temperature corresponds with a little blip higher in our sleep propensity. So, and this is something that everybody does. It's a worldwide phenomenon because it's controlled with our biology. It has nothing to do, it may have nothing to do, it might have something to do, but for most people it has nothing to do with how well or how not well you slept the night before. It has more to do with that little blip in your body temperature. So, the best thing to do for that afternoon feeling is go and get your blood moving, raise your body temperature, go for a walk around the block, something like that. But then your body temperature is normally going to rise, and that's when you feel, okay, I've gotten past that little, drowsy period in the afternoon. And then you can see the interaction with melatonin, and that really there's nothing going on until about 8, 9 o'clock when, in some places it would be getting dark, or at some times of the year it would be getting dark. And then there's a steep hike in our melatonin, corresponding with our sleep onset, and then it goes down as we sort of discharge our sleep need. Okay, so all of these things sort of work together to regulate our sleep. All right, so now that I've talked about some of the sleep physiology, the biology behind sleep, I know not everybody would probably be all that interested in that, but now we're going to focus on insomnia and how insomnia develops. Okay? Now, what constitutes insomnia? People throw this word around a lot, right? Now, for cats, this might correspond to what the cat experience of insomnia is, right? Let me get this straight. It's been 2 consecutive hours since you've slept? Now, when people come to see me and say, I have insomnia, there's a clinical criteria that we use to be able to diagnose somebody with insomnia. So as I'm going through these, you might want to check these off in your brain. So, if you're laid down intending to fall asleep, not just go to bed. A lot of people go to bed when they're bored, not because they're tired, right? So if you lay down intending to fall asleep and it takes you more than 30 minutes, possibly. If you wake up in the middle of the night and you can't fall asleep within 30 minutes, maybe. What about if you wake up in the morning, 5 o'clock in the morning, your alarm's not set to go off until 7 o'clock, right? So you lay there awake in bed for 2 hours, trying to get back to sleep. And this disrupts your functioning during the day, right? So maybe your memory and your concentration isn't as good, you're grouchy, you snap at people, your reaction time is slower, you don't feel motivated, you feel tired, you feel fatigued, you get colds, all that kind of stuff. And this happens frequently. So the occasional bad night of sleep is probably pretty normal. And your body can adjust because of that homeostatic mechanism like I explained. But if you're getting less sleep than you need, more so than you're getting as much sleep as you need, your body has a hard time compensating for that. So we use the criteria, if it happens more than 3 times a week for at least 1 month, then we're going, okay, you know what, there's a problem. We can also break it down into 3 further categories. So, acute or transient. So this is the sleep problems that happen that they don't last very long, maybe a few days. We also call this adjustment insomnia. It's usually related to a particular trigger or stressor. So for example, I might get into a fight with my partner, right? Because he didn't do something I wanted him to do, and so I'm mad at him, right? And I'm going to stew about it for about 3 days, and I'm not going to sleep because I'm going to plan how I'm going to make his life miserable, right? But then we talk, and then, he decides, okay, I'm going to do that for you, and I'm going to go, okay, I'm not going to be so hard on you, and then we're all lovey again, and then I sleep fine, right? So adjustment insomnia is different because you can either adjust to the stressor, or you can remove the stressor. So either I have a conversation with him and we work things out, or I dump him, right? Those are my two options. And then I sleep better either way, right? Okay. So short-term or subacute insomnia is something that maybe it's taken a little bit harder, it's more difficult for us to adjust to. Right? Often this happens with a diagnosis of cancer. You go into your oncologist, okay, when you've got cancer, and okay, well, what am I going to do? And it takes a lot longer. It's not something you can just adjust to really quickly. So what's important about the short-term insomnia is that people start engaging in behaviors during this period that are designed to help them cope with the sleep disturbances, but can actually serve to keep the sleep disturbances around. So maybe they start napping during the day. Or maybe they start taking over-the-counter sleeping medications. Or they say to themselves, you know what, I really need to sleep tonight. I'm going to go to bed at 9 o'clock and I'm going to try harder. I'm going to make myself sleep. Right? That doesn't work. You just end up getting more frustrated and you still lay in bed for 2 hours until you actually fall asleep. Okay? Or chronic. So when it happens for more than a month, it is becoming chronic, and that's really when it becomes a serious problem. Now, unfortunately, usually when I see people, it's been 5 years. I haven't slept in 5 years. Oh my gosh. Something has to be done. We can also break it down into subtypes. So some people only have a problem falling asleep. I just can't get to sleep. Once I get to sleep, I'm fine. We call that sleep onset insomnia. Difficulty staying asleep. So they say I can fall asleep in 5 minutes instantly, just like that. But then I keep on waking up. Wake up frequently during the night. That would be sleep maintenance insomnia. Now, waking up too early, again, sleep offset insomnia, and poor quality sleep, so non-restorative sleep. So if somebody is sleeping adequate amount of hours and they're still feeling tired, something else is going on. It's not only to have to do with your sleep. So when somebody comes in with this concern, I usually recommend a full physical plus a lot of other, check your thyroid, check your iron, all of those other things, because something else is going on if you're getting adequate hours and you're still not feeling rested and refreshed the next day. Now, when people talk to their doctors, they'll often say, I've got insomnia, I can't sleep. And the doctor will say, are you depressed? You say, no, I'm not depressed. I just can't sleep. You might be depressed because depression and insomnia can coexist, but they might not necessarily have anything to do with each other. You can be perfectly happy, you just can't sleep. But we do know that insomnia is often coexisting with other conditions. So if you have a pain condition, if you have depression, if you have anxiety, those things will often go along with insomnia. They might be there before, they might be there after. It might be something that you get after. I haven't slept in years and I'm just so anxious, right? Now that we know a little bit about sleep architecture and sleep stages, we can compare the sleep architecture of normal adults to people with insomnia. So you can see there the difference in the initial insomnia, that they're spending a lot of time awake, and then the middle insomnia, the sleep maintenance, you've got a lot of little awakenings, as well as the late insomnia, the sleep offset insomnia, that they're laying awake in bed before finally waking up in the morning. Now, most people who can't sleep or have difficulty sleeping will acknowledge that even 4 hours of good solid sleep is better than 8 hours of this disrupted sleep all the time. And that's one of the reasons that I'm going to make some of the recommendations that we do to work with your biological systems to get you a more efficient sleep instead of all of this broken sleep. Now, insomnia is something that is not only in your head, it also is in your body, so it affects both. But our sleep difficulties can become conditioned. Now, what I mean by this is if we pair something with something else often enough, that will be enough to trigger the occurrence of something. Now, I'll explain what I mean by that. So, your kitchen. At least 2 meals probably every day you spend in your kitchen. Okay. So has anybody ever found that they might eat supper and then it's an hour later and then they walk into their kitchen, maybe they're doing dishes or something like that, and they find themselves with their head in the fridge looking for something to eat? They're not hungry. They're in their kitchen, right? And the kitchen is enough to, because we've eaten in there so many times, we think, okay, well, we eat in the kitchen. I'm in the kitchen. I must be eating. I should be eating, right? Now, we can do that with the bed too. Now, once you have difficulties sleeping, if you pair your bed night after night, night after night with either arousal-producing thoughts or arousal-producing emotions. Now, arousal-producing thoughts and emotions, they kind of go along together, right? So if you're thinking, oh my God, okay, I have to do this tomorrow, this tomorrow, this tomorrow, this tomorrow, you start getting anxious. How am I going to do all that stuff? I'm not going to be able to get all that stuff done. If I don't get that stuff done, I'm going to get fired. If I get fired, I'm not going to be able to provide for my family. If I get for my family, then I'm going to be out on the street. How our brains just sort of like keep on going, right? Now, but it can also be associated with emotions that are arousal producing. So your attempts to sleep can get frustrating, right? I'm trying to sleep. You might get angry at your sleep, right? You might be worrying about things that are going to happen in the future, ruminating about things that have already happened in the past. All of these things produce an environment in our bedroom that's not very conducive to sleeping. Okay, so we condition ourselves that our bed equals not sleeping. And then we often find that we get this focus on our sleep too. It starts about 7 o'clock at night. We start going, okay, well, you know what, I gotta go to sleep. How am I gonna sleep if I don't sleep? So this starts early. And this is also how we can sleep in other places except our bed. So, I'll talk to people, I'll say, well, can you sleep on the couch? Oh yeah, I have no problem sleeping on the couch, right? Well, then your sleep system isn't broken. It's just a little bit skewed as to where you're supposed to be sleeping, right? So you can sleep in novel places in the absence of that conditioned stimuli, right? So it's your bed that you can't sleep in, but you can sleep on the couch. And it's not that people plan to do this thinking at night. It's usually that they're so busy during the day that they can distract their mind with other stuff. And then when you're trying to relax, that's when your mind goes, ha-ha, I've got you now. I'm going to make you think about all the stuff you don't want to think about. So this is where when people tell me, I just can't shut my mind off, that's a red flag for me. Okay, you know what, that really sounds like insomnia. Now, when our brain is active, our body is ready to react, right? Our body doesn't tell the difference between a real threat and a real threat and an imagined threat, right? We get the same sort of reaction. So if we're thinking about planning what we're going to do the next day, our body's ready to do what we're planning. Right? So that's where we feel physically wound up as well. Now, this is when we do engage in something called sleep extension. So we expand our sleep opportunity with low sleep efficiency, and I'll explain what that means. This is I'm going to go to bed early. I'm going to try harder to sleep, right? And sleep efficiency is a percentage of the amount of time you spend sleeping versus the amount of time you spend in bed. So if you spend 10 hours in bed, but you only spend 6 of those hours sleeping, you've got a 60% sleep efficiency. When I treat people, I get their sleep efficiency about 85% or higher is my goal. Now, so how does insomnia develop? It's typically not because of a snoring bed partner, but that might have something to do with it. All right, now, you can see here we've got premorbid or predisposing factors that we can't do much about. Okay, so these might be things like age, gender, genetics, right? We don't know much about the genetics of insomnia, but we do know that it tends to run in families. Oh, my mother wasn't a good sleeper either, right? So premorbid things, we can't do anything about the fact if we have a medical illness that causes pain or anything else like that. But then usually a precipitating event happens that puts us over the threshold for insomnia. So the precipitating factor puts us over the threshold, but then with time, we either adjust a little bit to whatever happened. Now, it doesn't have to exactly be one thing. It can be a combination of things, right? It can be one thing that just puts us over the threshold and we can't sleep anymore. Or it can be a combination, like something and then something else, and pretty soon you can't sleep anymore. But then when that goes down, usually we've started engaging in perpetuating behaviors. These are things that which make logical sense. Okay, you know what, I'll try that, but typically make things either stick around or get worse. So if somebody naps for 2 hours from 3 o'clock to 5 o'clock, now that you guys know about sleep pressure, you've just discharged a lot of your sleep pressure, right? So then, of course, you're not going to get tired when you want to go to bed at 11 o'clock because you don't have as much sleep pressure built up in order to fall asleep at your regular time. And then you sleep less and then you nap the next day and it creates this vicious cycle. Now, once you've got these perpetuating behaviors and then on top of the precipitating, you often have this conditioned arousal. So that is the experience of, yeah, okay, as soon as I go to bed, my mind turns on. Now, what I do is I knock out, first of all, the perpetuating behaviors, get you sleeping on a nice schedule again. And then we work on the conditioned arousal. So we reassociate your bed with successful sleep experiences, and then it's not so much of a struggle anymore. So it actually becomes something you look forward to instead of something you dread. All right, now, what can everybody do to promote a good sleep? Now, it's not using wireless sleep technology. So first of all, determine how many hours of sleep you need. And now that you know that 8 hours isn't optimal, it's usually based on what you feel good after you've had, right? So if it's 6 hours, 7 hours, 5 hours, 9 hours, right? Think about, okay, even if you're not sleeping well now, when you were sleeping well before, how much sleep were you getting? If you don't know, keep a sleep diary. What time did I go to bed? What time did I get up? How many hours or how many times did I wake up in the middle of the night? How much time did I spend awake during the night? So figure out exactly how much time you're sleeping. Now, some people have been wrong. They've given you wrong advice. They said keep your bedtime the same. That's wrong. It's actually backwards. It's keep your wake-up time the same. That is the key. That is the most important thing that sets your sleep pressure, right? And it is the only thing you can control. You can control what time you get out of bed in the morning, right? Yeah, most people alarm clock, everything else like that. You can't control what time you fall asleep. You can say, I'm going to go to bed at 10, but that's not going to say you're going to fall asleep at 10. Your brain and your body decides when you fall asleep. So it's the most important thing to set your wake-up time and keep that consistent regardless of what time you went to bed, within about an hour, okay? And the thing that we don't do, that we need to do, is give ourselves a buffer zone of 90 minutes before bed. This is what we do for kids. It works miraculously, right? You know, they have a snack, they have a warm bath, you get them into the comfy PJs, you read them a story, you dim the lights, you lay them down, all that kind of stuff. Whew, poof, they're asleep, right? What do we do before bed? We do the extra load of laundry, we send off a couple of emails, we're running around, maybe we pick up something from the store that we need for breakfast the next morning. We're doing a lot of stuff. We're definitely not calming down. Right? So this 90-minute buffer zone means that dim light. We know that we're working with our melatonin system, right? So if it's summertime and you want to go to bed at 10 o'clock, you need to make artificial dim light, right? You need to make sure that curtains are drawn, everything is dim. Okay? You want to be sedentary. You don't want to be moving around because that's in opposition to what our brain knows of when we're sleeping, right? When we're sleeping, we're not moving. We're sedentary when we're sleeping. So you want to be sedentary and you want to be engaging in relaxing and enjoyable activities. All right? So, important, something that as adults we pay little attention to, but it is a key determinant. And it doesn't matter what time you go to bed. Usually what happens with people is that their body is going to take this 90-minute buffer zone anyways. Right? So if you're doing the laundry and you're doing everything and you're, sending off emails and then you go to bed and you're awake for 90 minutes, what's that? That's your body winding down. That's your buffer zone. Okay, so give that to your body so it's not stealing from the number of hours you need to sleep. Okay, no computer during this time. Like I mentioned before, computers are awful. Television's not bad. Television is usually far enough away that it doesn't stop the production of melatonin, but computer screens are bright enough. We usually even make them even brighter so we can see, right? So no computer, 90 minutes before bed. Now, the other thing too is we want to lie down only when we're sleepy, not based on the clock. Oh, it's 10 o'clock, I need to go to bed. It's when we're sleepy. It's not when we're bored, and it's not when we're tired. Tired is different than sleepy. Tired is I feel tired, I don't want to do anything. Right? Sleepy is, right? I'm sleeping, like my head is bobbing, my eyelids are heavy, I'm having a difficult time staying awake. That is sleepy, okay? You want to make sure your sleep drive is really primed. If you think about, those cars that used to have to step on the gas and you have to prime them really good before the engine would start, we want to make sure that we're really, really sleepy before we go to bed. And then we want to avoid any behavior in bed other than sleep or sex. Unless you're the type of reader that keeps on reading the same 2 pages over and over again because you fall asleep with the book on your chest, right? That's fine. Usually that's probably a pretty good cue for you that as soon as you pick up that book, that's the cue for you, I should fall asleep, right? But if you're the type of reader that keeps on reading the same, or reads like, 6 chapters or something like that, and it's 2 o'clock in the morning and you're so engaged in this book, then reading is not a good activity for you to do in bed. Now, this is the thing that people don't want to do. And it's recommended, and the reason it's recommended is because you don't want your bed to be a place that you lay awake. So if you're not awake or if you're not asleep within about 15 minutes, get up and go do something else. Go continue your buffer zone, right? Because you're not tired enough to fall asleep yet. What happens is people might do this, but they wait too long. They go, okay, well, you know what, it's been an hour, now I'm mad and frustrated, now I'm going to get out of bed, right? But then they got to wait and they got to calm down. But if you would have gotten out of bed at 15 minutes, then you wouldn't have let yourself get all mad, and then you probably would have gotten tired faster if you would have gotten out of bed earlier. Right? It's to plan for in advance. Plan to have your slippers beside the bed and your robe and, you know, a blanket and a book. Plan what you're going to do. So it's not a thing where I know I should get out of bed, but what am I going to do? I don't, you know, so make it easy for you to get out of bed. And then return to bed when you're sleepy. Okay? You're working at reconditioning your bed to be a place where you sleep instead of a place where you think and you worry and you plan and you get frustrated and you lay ultimately awake. All right, so there's a lot of good sleep habits. This is called sleep hygiene. A lot of stuff that people already hear a lot about. Really, what's important to know are these things, right? Naps. Now, if you can take a nap and you can still fall asleep at night in your regular time, naps are fine. Okay? That's the rule. Now, if you take a nap and then you can't fall asleep at night, that means you didn't need that nap. Right? Naps are like energy bars. They're concentrated pockets of really deep sleep, which is why we feel good after having them, right? But that steals from your sleep at night. You know, if you're undergoing treatments or you're recovering or you have fatigue, you know, you might need to sit down or you might need to rest, you might need to nap, but base that on whether you can sleep at night. Set a consistent bedtime routine. I know people, as soon as they brush their teeth, that's the cue for them to fall asleep, okay? Set consistent sleep and wake schedules. Like I said, the wake is most important there. Avoiding stimulants before bed and making sure your bedroom is the only place that you sleep and not eat, read, or watch television. Now, relaxation therapy. Now, because we know the mind and the body are connected, we can target the mind or we can target the body, and they both influence each other. So relaxation therapy can often help at night. Now, a lot of the time, we don't have a direct vent to our frustration, right? So we need to do other activities in order to relax our bodies. Now, it really depends on what works for you. Some people like something called progressive muscle relaxation, which is a technique where you go through and you systematically tense and relax 16 major muscle groups in your body, producing a feeling of heaviness, warmth, and just contentment. Some people like imagery, imagining a place that they've been to or a place that they want to be to. It's pleasant, allows them to fall into a slumber relatively nicely. Some people like deep breathing, some people like prayer, some people like meditation. Something that works for you. It's different for each person, but relaxation is a very good way to calm down before bed. Now, okay, so what if I need more help? So if I have stimulated you today to think, okay, you know what, I really should know more about this. It's been a problem for me for a long time. I need to go to a sleep disorder clinic. And for people who can't read that, it says the good news is that you don't have apnea. The bad news is that Fluffy sleeps on your face. So if I need more help, there is a sleep center here at the Foothills. That is the website. There you can go there, you can take control of your own health care, you can print off that referral form, you can take it to your doctor. Doctor's going to fill it out, fax it in. Depending on what your problem is, if you're coming there for sleep apnea or something else like that, you may wait a little bit longer because you're going to need a diagnostic test. If you're just wanting treatment for insomnia, you'd probably get in there about 4 to 6 months. So it's a little bit faster. But it's a you don't pay for this service. So if you don't pay, you wait. That's really how it goes, really. Now, if you want to pay, you've got money and you want to see somebody faster, then you go to the Center for Sleep and Human Performance. Now, they don't do as much with insomnia, but if there's any other sleep disorders, such as sleep apnea, they do deal with that. Now, for people who like helping themselves, a self-help book that I actually have up here just for insomnia. You can take a look at it. It's available. You can purchase it online. It's very good. It deals with the same techniques that I use as cognitive behavior therapy for insomnia. And if you are interested in the work that I do, it's called the I Can Sleep program. And what it is it compares two behavioral programs. It's a research program, and it runs 3 times a year in the fall, winter, and spring and summer. They are group programs, and the classes are held 90 minutes long and held weekly for 8 weeks. In my program, all people complete a formal sleep assessment with a sleep watch. And if you want more information about that, I can definitely give that for you. And in order to make me seem not only funny, but also wise, I also want to note that Homer, even back when he was around, recognized that there's a time for many words, and there is also a time for sleep. So with that, I will close on time, and I'll open it up if you have any questions, or I will be around as well. So. Any questions? Yes?
Does melatonin help produce sleep, or does it evolve because you're sleeping?
So melatonin is not good for the treatment of insomnia. It's not good at inducing sleep. So it's not a sedative or a hypnotic. A lot of people who have sleep problems, they'll say, oh, maybe I should take melatonin. They end up wasting their money, is basically what they do. Melatonin is only good for regulating your sleep and wake cycles, right? So it's produced in the absence of light, and it's suppressed in the presence of light. So the only clinical way that we use melatonin is if somebody has what's called a delayed or an advanced sleep phase syndrome. So a delayed sleep phase syndrome is a fancy word for you're a night owl, right? So those are the people who don't get tired until like 3, 4 in the morning, but then they sleep until noon. Right? Now, if they have a day job, that becomes really problematic. So you can reset their circadian clock using melatonin, among other things, if properly timed earlier, to make their body think that, okay, it's time for sleep. The problem with insomnia is that insomnia really isn't a problem with your circadian rhythms. Your melatonin is being produced like normal, but it's usually something else that's going on. You're thinking you're getting yourself activated before bed. Does that answer your question? Okay.
On your folder here, it's, the first thing is go to bed only when sleepy, and then you jump to number 7, set a consistent sleep and wake schedule. Well, my wake schedule is 6 o'clock, but if I set going to bed at 10, because I need 8 hours of sleep, but if I'm not sleepy and don't get to sleep till 2, the mathematics doesn't work for me.
Mm-hmm. So that's a lot of people will actually find that. They'll say, all right, I am getting up at the same time, but my bedtime isn't corresponding with my wake-up time. So what he was saying was, I get up at 6, and I need 8 hours, so then I try to go to bed at 10, but I'm not tired. So my question to you would be, I would be wondering how strong your buffer zone is. How many things, like, so if you wanted to go to bed at 10, that means your buffer zone should be about 8:30. So start winding down, start dimming the lights, start doing everything else that your body would associate with sleep, about 90 minutes, in order to transition your body from being awake to being asleep. Does that help?
Okay.
Okay.
How is yawning related to sleep?
How is yawning related to sleep? Yawning is something that scientists, they figure it has something to do with oxygen levels in our blood, but we also know it's contagious. So yawning is something that scientists haven't really been able to concretely pinpoint yet, because it doesn't even have to be people of the same or the same species. Dogs yawn, and that can like trigger a human yawn or something like that. But we do know that yawning also happens before we get sleepy, which is probably having to do with oxygen levels in our blood.
I was just giggling because somebody started yawning as soon as you started talking about yawning.
Sheila, this is an excellent presentation, and our particular group has a certain bias, at least the men here. In your research, have you attempted to look at the conditions that are affecting, for example, a prostate cancer group of men versus other, if you will, men affected by normal conditions or other conditions, what have you? And I can think that, my last night I was up 6 times, so, and I need to condition somehow my bladder, and I don't yet know how to do that. That's 3.5 years into this game. So.
Yes. So there are some specific problems that, depending on which area of the body that you've had cancer, are going to become more problematic. The ones that are most problematic for people with prostate cancer are hot flashes and urinary urgency. Right? So the urinary urgency, it all depends. If you're doing everything else right in terms of limiting water intake and everything else, and you're probably on some medication, that's a little bit more difficult for behavioral interventions to target. Right? But hot flashes are something that you can target behaviorally. Now, what you do with hot flashes is you can't prevent the occurrence of hot flashes, but you can reduce the severity. Now, you do that by deep diaphragmatic breathing. Now, what that does is if you slow down your breathing, your heart automatically slows down, right? And if you slow down your cardiovascular system, the hot flash doesn't last as long. Right, so you can, it's still gonna come on, but it's gonna be shorter, and it's gonna be easier to deal with if you start deep diaphragmatic breathing at the onset of the hot flash. Now, we've got 113 participants going through our program right now. I haven't done any sort of preliminary analysis because we have people with almost every type of cancer participating in the program. So I would be very curious to find out if there's differential results. I know that we've had people from the group participate in the program, and even with the things that they can't do anything about, they still have been able to improve their sleep. So, but yeah, that's kind of with the urinary urgency, there's less we can do, but with hot flashes, we can definitely work with that. Does that answer your question? Okay. All right.